Hello students. So next in neurological emergencies we will discuss intracerebral hemorrhage. So we will discuss in neurological emergencies intracerebral hemorrhage. We will restrict ourselves to the emergency department management and disposition of the patient to the concerned center. Okay. So how do I manage intracerebral hemorrhage, suspected intracerebral hemorrhage in emergency department? Okay. Now intracerebral hemorrhage is 10 to 15% of stroke is intracerebral, cause of stroke is intracerebral hemorrhage, and it is of course caused by rupture of blood vessel in the brain parenchyma, right? Rupture of blood vessel in brain parenchyma. How does it present? What is the presentation? Presentation is headache, altered level of consciousness and focal neurological symptoms. Okay, so one of the emergent differential diagnosis of headache is intracerebral hemorrhage. Whenever headache presents with altered level of consciousness and focal neurological symptoms, focal neurological deficits, ICH, intracranial hemorrhage, should come in our mind. Okay, there are other differential diagnoses also for this, but ICH should be one of our differential diagnosis, right? In my subsequent slides, I will tell you how to approach this patient. So what is the etiology of intracerebral hemorrhage? Hypertension, trauma, cerebral amyloid angiography, vascular malformation, right? These are etiology. Hypertension is the most common etiology, long-standing hypertension, right? ICH is more commonly seen in older patients. Subarachnoid hemorrhage has younger patients, predisposition in younger patients as well, right? But ICH is more commonly seen in older patients. Long-standing hypertension results in damage of the perforating arteries, perforating arteries deep within the brain parenchyma structures, like deep penetrating arteries, which nervates thalamus, basal ganglion, pons, right? In these arteries, right, hemorrhage can happen because of long-standing hypertension, which can extend into ventricles as well. So intraventricular hemorrhage can also happen. So intracranial hemorrhage can also happen deep in ventricles, but more commonly, the more common site are, the most common location of intracranial hemorrhage are basal ganglion, thalamus, pons, cerebellum. Basal ganglion, putamen, thalamus, pons and cerebellum, right? Because long-standing hypertension poses a huge risk to these deep penetrating arteries, so there is a high risk of hemorrhage in these arteries. Okay, now ICH produces multiple symptoms, and none of the symptoms are specific to intracranial hemorrhage, right? None of the symptom is a very specific symptom of intracranial hemorrhage, so it is very difficult to differentiate it from ischemic stroke, right? Very difficult to differentiate it from acute meningitis or subarachnoid hemorrhage, right? The only thing which can differentiate is the ICH from other conditions producing this kind of headache with focal neurological symptoms and altered sensorium is your imaging, neuroimaging. So whenever a patient presents with severe headache, presents with focal neurological deficit, altered sensorium, neuroimaging is done as fast as possible, so that we know if there is a preventable cause of this problem, and as fast as possible we can get a neuroimaging done for further planning our management. What would be the best management for this particular patient, right? But before shifting the patient for neuroimaging, we have to do some things for basic management, which I will tell you, right? Remember, any patient presenting with sudden onset of acute neurological symptoms, headache, acute neurological deficit, altered sensorium, ICH, has to be a differential diagnosis. It has to be in a differential diagnosis. So how do I manage when I suspect, I haven't done a neuroimaging yet? Before neuroimaging, we have to take care of a few other things, right? what is done in these patients with acute neurological insult? What is the initial survey and primary management? So initial survey and primary management. Okay. Whenever a patient with any type of intracranial hemorrhage, right, number of times they present with coma, rapidly declining the consciousness and seizure. If they are stable, we have time, we can manage, we can go for neuroimaging and etc. after stabilizing the other things. But if a patient presents with coma, rapidly deteriorating level of consciousness, seizure, the priority is on ABC, that is airway, breathing, circulation, and D also, of course, ABCD, disability, right? How much disability is present in the patient, neurological disability present in the patient. So if patient is comatose, if patient is declining, the consciousness is declining, if patient cannot protect his airway from aspiration, we always secure the airway, right? So if there is any concern in oxygenation, ventilation and airway protection, or if there is a prolonged seizure or rapidly deteriorating clinical status, right, we go for a neuroprotective rapid sequence intubation protocol. What is neuroprotective rapid sequence intubation protocol? Guys, in ICH, already bleeding is present in the parenchyma of the brain. So intracranial pressure is high. So we have to secure the airway, but we have to go for neuroprotective intubation technique. We don't have to let any of our maneuver to increase the intracranial pressure of the body, of the person. We should not do anything which will further increase the intracranial pressure, further increases the blood pressure, heart rate, etc. of the patient. We do not want, during any procedure of ours, sympathetic stimulation should happen to the patient. So we should accordingly manage the patient. We should accordingly manage the patient, right? So always an induction agent is given to the patient, a neuromuscular blocker is given to the patient, and then only patient is intubated. And maximum times ICH is sudden. So maybe we don't know the status of the last meal of the patient, empty stomach of the patient, whether the patient is, there is a chances of aspiration or not in the patient. So rapid sequence intubation is preferred. Mostly in emergency intubation, if we don't have the status of the last meal of the patient, a rapid sequence intubation is preferred. Okay. Well, how do we do? We proceed with a brief assessment of breathing, circulation, right, and disability. We are assessing the patient's airway, breathing, circulation, right, and meanwhile we pre-oxygenate the patient and optimize. I am talking about how do we do a neuroprotective intubation in these patients. So we are doing number of things together. We are assessing the patient and meanwhile we are oxygenating the patient, right, so that patient's oxygenation is optimum, and meanwhile the intubation equipments, drugs, etc. are being prepared, right? Number of times, if the time permits, before intubation, before giving the drugs for intubation, we document a initial neurological examination. Now if we have in emergency department done neurological examination prior to intubation and all, it would be a great help for the neurosurgeons for further planning their course, right? So a very fast neurological examination is preferred. So maybe we will do a GCS scoring of the patient. We will see the pupillary size and pupillary reactivity, motor strength in all four limbs, sensation and reflexes, right, if the time permits. Minimum GCS is done. Pre-intubation GCS is very fast done for the patient. Maybe very fast we would see the pupillary reflexes, pupillary size, right, and we will see the motor, and maybe if the time permits, sensation and reflexes also we can check. So a pre-intubation neurological assessment would be very helpful for planning the latter treatment for the neurosurgeon. So it is done prior. Okay. Then blood glucose level is always checked, and if it is required, we give dextrose to the patient. These patients, there may be a possibility of rapid increase in the hemorrhage in the intracranial parenchyma, brain parenchyma, the bleeding is increasing, the hemorrhage is increasing. So because of increased intracranial hemorrhage, there is intracranial hemorrhage, intracranial pressure increases, and there is a chance of imminent herniation of the brain, right? Brain herniation. In near future, because of very high ICP, the herniation is possible. So as ICP is increasing, there is a physiological response of high ICP, Cushing's triad, right? This Cushing triad, we look for the signs of the Cushing triads. Patient's blood pressure is increased, right? Bradycardia, right? Heart rate will decrease, and patient has abnormal breathing pattern abnormal. Pupillary reflexes, lack of pupillary reaction or pupillary asymmetry would be there. No reaction, no pupillary reaction or pupillary asymmetry would be there. When I am seeing these features, hypertension, these are features of Cushing triad, hypertension, bradycardia and abnormal respiratory pattern. Hypertension, bradycardia, abnormal respiratory pattern, part of Cushing triad. Other things which can accompany this would be a lack of pupillary response or asymmetry of the pupils. Then there is a chance of imminent herniation of the brain. So here we will very fast do some emergent intervention to decrease ICP, which I will tell you in few minutes in the subsequent slides. How do I decrease the intracranial pressure in these patients in emergency department itself? Okay. So I am doing the examination of patients, and meanwhile I am securing the airway and seeing the bleeding pattern, managing the circulation, and doing the examination of the patient in primary survey and initial stabilization. We are doing a lot of things together. Now, once I have stabilized the patient, now I will work towards the diagnosis, to establish the diagnosis. As fast as I can establish the diagnosis would be best for the patient, would be very beneficial for the patient. So I would do as fast as possible a NCCT in these patients. Head CT is the mainstay of diagnosis of intracranial hemorrhage. On CT, what we have to look for? In acute phase, the blood is hyperdense compared to the surrounding brain tissues, so it will look whiter. In subacute phase, that is 3 to 10 days, it is isodense. So this is a time period we have to keep in mind that on CT, the ICH can be missed. And afterwards, it becomes hypodense, right? It appears hypodense compared to surrounding blood tissue. It becomes darker relative to the brain tissue. Okay. So we have to keep in mind the history of the symptoms, when the history of the symptom came. And accordingly, the things will appear on the CT scan. If we have large volume of blood, then there are few features which are very clear in CT. There would be midline shift, right? Ipsilateral compression of the ventricles would be compressed, right? With or without the contralateral ventricular enlargement. The sulci and gyri of the brain would be obliterated because of increased intracranial pressure. And your gray matter and white matter junction would be blurred. So fineness of the CT scan would be lost. Midline shift would be there because of increased intracranial pressure. Right? Ipsilateral compression of the ventricles would be there. Obliteration of the sulci would be there. And there would be blurring of gray-white junction. So these are the few features of intracranial hemorrhage. Right? So what is happening? The midline shift is there. And what is happening? You can see this is a huge hemorrhage. Right? Huge hemorrhage which has obliterated the ventricles. Huge hemorrhage which has obliterated the ventricles. These are the huge hemorrhage which is pressing the ventricles, right? So in this there is a midline shift and one of the ventricles is not visible, right? A huge intracranial hemorrhage, right? So this would be seen in acute phases. Okay, number of time the intracranial hemorrhage is in subarachnoid space only. The hypertensive is in subarachnoid space only. And number of time it is subarachnoid hemorrhage or intracranial hemorrhage. Number of time it is difficult to diagnose, right? So in that case, we can go for something called lumbar puncture. And in lumbar puncture, what happens? If xanthochromia is there, that it is most probably subarachnoid hemorrhage. Okay, how do I manage intracranial hemorrhage? So as I told, as we have already done in primary survey and initial stabilization A, B, C, D, we have to discontinue or reverse anticoagulation. There are so many, mostly old hypertensive people come up with this. So they may be on anticoagulants. So we may need to reverse those anticoagulants immediately in emergency department itself, right? Then we need to prevent hypotension, hypoxia. So oxygen always has to be attached. Oxygenation has to be optimized. Blood pressure needs to be optimized. We need to control intracranial pressure. ICP needs to be controlled, right? And if patient have any seizure, immediately we have to prevent it, right? Now in ICH, clear-cut benefits unlike subarachnoid hemorrhage has been shown with anti-seizure prophylaxis, right? So we need to start anti-seizure prophylaxis, and it depends number of time on decision on type of bleeding and amount of bleeding, right? If patient's core temperature is increasing, right, we have to aggressively manage any fever, any infection, right? We have to maintain the blood sugar. I talked about Cushing triad. If patient's blood pressure is increasing, heart rate is decreasing, and respiratory pattern has changed, right? Respiratory pattern has changed, then ICP has increased. So there is an imminent threat of brain herniation. So we have to do something to decrease the intracranial pressure of the patient. So ICP control can be managed by monitoring or lowering the blood pressure in consultation with neurosurgeons. Elevate the head of the bed with 30 degree, elevate the bed so the ICP, venous return of brain, increases better. Provide adequate analgesia and sedation. And in case of rapidly increasing ICP, right, mannitol can be considered, or mild hyperventilation. Nowadays, CO2 is not targeted around 20, 24, right? 30 mm of Hg, right? We have to keep CO2. Basically, instead of maintaining hypocapnia, we have to maintain a normocapnia, near about normocapnia. So maybe a little mild hyperventilation will help, right? So the mannitol can be given, mild hyperventilation can be done, and ICP needs to be lowered, right? Now, vast majority of patient of intracranial hemorrhage, once stabilized in emergency, airway secured, breathing fine, circulation fine, needs to be conservatively managed under close observation in neurosurgical ICU. So they are disposed, right, to a neurosurgical ICU where intensive care, physiotherapy, everything is present. So if the center has the facility, then the patient is shifted to the neurosurgical ICU, or patient is shifted to the center after initial stabilization and management, where a proper care of the patient can be taken in neurosurgical ICU. Okay, so patient is disposed to the neurosurgical ICU for further management after initial stabilization. Okay, thank you.